Hello, everyone. It's Dr. Marty Ross here, and this is another Conversations with Marty Ross MD tonight. As you know, this is a webinar where we're going to discuss Lyme disease. I'm glad to see a lot of returning people here again tonight, which I think means you're probably getting some good value here. And I'm also pleased to see that we have a number of new people here tonight as well, too. For those of you that are here, and especially the new people, the way that you participate, there's actually a couple ways. Number one, you can write your question to me in the chat box that is on the bottom of the right-hand side of the screen. All right, so go bold on your first time. And the only thing I ask, if you do decide to write a question to me, do not hit the enter key until the whole question is written. If you try to use your enter key to create paragraphs, it sends multiple parts of your question to me, and it gets really hard to track from my side of the screen, okay? And then second way you participate is see what questions that I respond to here tonight, and see what I say to those, basically, because there's always a lot of explanations that I do, and a number of things you're probably going to be able to learn about just by listening to what the responses are here tonight too. Okay, and let's see here. So as usual, I am creating a recording of tonight's webinar. My intention is that I have that all edited and sent out to you with a link in an email tomorrow morning. That usually is somewhere around 9 to 9:30 a.m. Austin, Texas time. All right, so hopefully hopefully that works out okay. We'll see how that goes tonight. Sometimes the doing this does not turn out quite as planned. Sometimes I run into some technical problems, basically. Okay, so we'll have to see what happens with that. Hold on a minute, everyone. I'm just having my camera's just not quite set up here, right? Let's see. That might work a little bit better. Anyhow, maybe not. I'm using my camera. I'm using Chrome now has a way that it will auto adjust your camera for you if you use your phone as your camera, and it keeps shifting me around. So I'm not sure if I'm going to keep using this over the long term, but that's what we're doing tonight. Tomorrow morning, when you get that email from me, you can also sign up for the next webinar. At this point, our next webinar is supposed to be on Thursday, but I'm likely to move that to Wednesday. The reason is I've got to have a conflict on Thursday, and I'm trying to see. I think I'm going to wind up going to that other event on Thursday, and therefore I will move the webinar till Wednesday. But I'll let you know that tomorrow morning when I send that email out as well. All right. And so I think that pretty much takes care of all the background stuff here. Let's go ahead and get started. Oh, the other thing, if you're in the live version, you're going to be able to see the questions posted on the bottom of your screen. I will read them out loud, though, because the posted questions don't show up in the recorded version. Okay? All right. So let's go ahead and get started here. So hi, Maria. Let's see. Hi, Dr. Ross. So many questions. I just had fresh acute Lyme disease, 8 weeks, 2 times 200 milligrams of doxycycline, your advice. Thank you. Lumbar kinase. Everything has gotten better. Only the bladder is very bad. Overactive burning bladder, incontinence. What is your experience on that subject? Which pathogens can cause this, or is it methyl activation syndrome? What is the starting point in getting better with the bladder? Do you have any advice on how to get rid of the electrosensitivity? The other question, methylene blue and methyl activation syndrome. Could you please give recommendations how very sensitive people should start taking methylene blue? Methylene blue in pharmaceutical grade is impossible to buy in Europe, only contaminated with mercury. Is there a safe source to order from the USA? Kind and grateful greetings from the Netherlands. Well, welcome here tonight. Welcome from across the pond there. All right, so let's just kind of work through these things one at a time. So first of all, if you're having a lot of bladder irritation, you should do the basic workup that anyone should, whether they have tick-borne illnesses or not. And that is that your doctors should look at your urine, do some testing on it, make sure that you don't have a regular bladder infection. Okay, all right. But if you don't, then there is a likelihood that you may have a condition which is called interstitial cystitis, which is there's an inflammation of the lining of the bladder that is caused usually by Bartonella, sometimes by Lyme. So what you've described here already makes me wonder if you may have some Bartonella involved here. Other symptoms that could suggest Bartonella, just general symptoms, are if you're still having a lot of cognitive dysfunction, that sometimes is Bartonella, sometimes is Lyme. Pain on the soles of the feet would be a Bartonella symptom. Other symptoms suggesting Bartonella could be neurologic symptoms like burning or decreased sensation, having a hard time feeling things. Sometimes tremors and shakes can indicate Bartonella. And let's see here. Oh, a neuropsych problem. So having a lot of ongoing anxiety sometimes can be part of Bartonella, or depression can be part of Bartonella as well too, right? So you may want to take a look at my article on how to diagnose Bartonella based on symptoms. I'll show that to you here in a little bit. Review those symptoms and see if there's enough there that says maybe you have Bartonella. Interstitial cystitis would be a condition that makes me wonder about that too, okay? So you may need to look at getting some help from docs there to either prescribe things for Bartonella, or you could look at some of the recommendations I have on herbal options to treat Bartonella as well too. In other words, to kill Bartonella, all right? Let's see here. And then, what is the starting point? All right, so we talked about your bladder already. Let's see, Methylene Blue and mast activation. Could you please give recommendations how very sensitive people should take Methylene Blue? Yeah, I mean, Methylene Blue is, you have no greater chance of having a reaction to Methylene Blue as you do anything else. So if you happened to have tolerated your doxycycline okay and weren't super sensitive to that, there's a good likelihood you probably would not be on Methylene Blue. I usually will have my patients just start at 50 milligrams twice a day. I know there's another physician here in the States that uses a lot of Methylene Blue, and he usually will start people at 25 milligrams twice a day, okay? Regarding the Methylene Blue, I don't have a good source for it. I mean, the one thing I worry about people buying this stuff online is I agree. I think there can be a lot of contaminants, and you really don't know what you're getting with it. Here in the States, fortunately, we have a couple pharmacies that are compounding it. One of those is a pharmacy down in St. Petersburg, Florida called InfuServe. And then there's another company here near me, actually, just north of Austin, in a place called Cedar Park, Texas, called PD Labs, that is also doing that too. Now, I know with some of my European patients, what I have been able to do before for them is send a prescription to either one of those pharmacies, who would then mail it to a local U.S. address of a friend they might have, for instance, and then that friend would make sure to figure out how to forward it on to them. But I don't, I'm not saying I recommend that. I'm saying that's what we've been able to work out here before. I don't know where you can get Methylene Blue over in Europe, unfortunately. Let's see. Yeah, I think that kind of takes care of our questions there. So let me just do a quick screen share here for you and show you where you can look at some resources. All right. So this is my Lyme disease information site, Treat Lyme by Marty Ross MD. And in terms of how to diagnose Bartonella, and I review testing as well as symptoms, take a look at this article here, How to Diagnose Bartonella and Chronic Lyme Disease, okay? And then in terms of treatment options that you would have for Bartonella, take a look at this article called Kills Bartonella Brief Guide, where I review herbal and prescription options. Let me just see here. So I'm just, so in terms of the herbal options, take a look at this tier 2 Bartonella treatment approach. And you could either go with the Houttenia, Sida acuta, liposomal cinnamon clove oregano oil, or more recently, over the last year, I had started using a combination of cryptolepis and Japanese knotweed based on some research that came out about the usefulness of those from Johns Hopkins University. But those are some options for you to consider if you can't get prescription medications for you, okay? And everyone who's wondering about Methylene Blue, I cover Methylene Blue in this article as well too, okay? All right. Thanks for that question, Maria. Good luck. Hello, Patricia. Let's see. Hello, Dr. Ross. Years into treatment for mold and co-infections, I seem to have reached a plateau. Last Identic shows Lyme-Bartonella. Last real-time lab results positive for all 5 categories of mold and mosaic. Shows ochratoxin highest ever, and also gliotoxin and citrinin. My current doc wants to focus on the mold, so I've started on cholestyramine. In addition, glutathione, N-acetylcysteine, and Saccharomyces for the ochratoxin. Taking phosphatidylcholine, Tudca live essence for liver support. I continue with methylene blue, nystatin, and low dose naltrexone, which I have been on for 6 months plus. Started itraconazole 100 milligram 2 times a week, and beg nose spray based on positive results from microbiology diagnostics. Question is, do you think based on ongoing foot pain, I should add Bart herbals? How does one determine if mold has colonized, and what is the best course of action for that? Okay. So just a few comments here. I honestly don't know why my colleagues continue to repeat testing somebody to see if they still have infections once they've tested positive once. The reality is the testing that we do through IGeneX is basically antibody test. It's looking to see that Immunoglobulin and Western blot and IFA testing that you can do through IGeneX are looking to see if your immune system is making antibodies against these infections. And whenever you even get well, there's a good chance your immune system is still going to be making antibodies. Some of my colleagues falsely believe, in my opinion, that they think that if you're having less reactive Western blots or immunoblots, that somehow indicates that the infection is not as active. And what I would say is there's no science that proves that. The other thing I want you to know is if they falsely believe that for some reason, if you don't have any reaction on immunoblot or Western blot, that the infection is gone. Well, it just may mean your immune system is not making antibodies at the moment they draw, or if there is enough infection going on, the infections may be suppressing your immune system in a way that you're not having a strong antibody reaction, okay? So the reality is we do not have any testing that proves where you are. And I know a number of my colleagues keep trying to do this, and I strongly disagree with the approach. There is no testing that's ever been validated to show that you are done. We don't have an accurate, the best way we can tell if you're done is if we could measure what's known as the germ load in you. And we don't have a way of measuring germ load. There is no test that does that, okay? So I don't know what that means to have a finding that says that they're still positive. That doesn't necessarily mean Lyme and Bart are still in you. It just may mean you're having an immune reaction, and maybe all the antibiotics you did over time got rid of those. Maybe, okay? I do agree, though, when you have a situation where somebody's been treated for a long time and they keep having high mold toxin levels, that does become a very important area to focus on, because having elevated mold toxins is going to inflame your immune system and is going to trigger your immune system to make too many cytokines. As many of you know, the main reason you have symptoms called Lyme disease symptoms, or the main reason you have symptoms called mold toxicity symptoms, is due to your immune system trying to deal with those problems, manufacturing a group of chemicals called cytokines, okay? So cytokines are good and bad. On the good side, they turn the immune system on. But if the immune system isn't doing a good job, it's going to try harder and harder, and eventually it makes too many cytokines, all right? So, just having, so the fact that you still are having a cytokine excess syndrome, that's what it sounds like to me, and you're still having elevated mold toxins, you got to look at that, okay? So in terms of mold toxicity, you're either getting if you've been treating for mold toxicity for a while and you still are having elevated mold toxins, there's a couple possibilities of what's going on. Number one, it could be that you are in a building still that has mold, all right? Or your work environment has mold. In other words, you may still be being exposed from your environment. And so if you have not done so, and I assume you probably have, you need to get a good mold inspection done of your home and see if they can identify, is your home still contaminated? Is the home still poisoning you? Okay. Now, if your home is not poisoning you anymore, then we have to start wondering if you have developed what's known as mold spore colonization within your nose passages or your intestines, okay? And so what happens is there's a small percentage of people, not all people get colonized. I mean, if you read Dr. Neil Nathan that talks about mold, and even Dr. Jill Krista that talk about mold, they're convinced that everyone is colonized with mold spores. And I disagree, because in my practice, I was able to get 80% of patients I treated for mold toxicity well without ever having to treat them for mold spore colonization, okay? But there is a small percentage of people that when they were in that building that had mold, and they were in that building where they breathed in all the mold toxins that got trapped in them, sometimes the mold spores from that building also got trapped in them, okay, either in their nose passages or in their intestines. And when those mold spores get trapped there, they can start producing their own toxins. And in a sense, the way I describe it, you become your own brew pub for your toxins, okay? Now, the problem is we do not have an accurate test that tells us if you are colonized and if you are making toxins in your nose passages or your intestines, okay? And part of the problem is probably most people have some degree of mold spores within their nasal passages. It's a common thing. We breathe them in, they get trapped there. But in most people, they don't go on to start producing toxins. So there's no reliable test that tells us we could test for mold spores in your nasal passages, but it doesn't tell us, are they producing toxins? So that's what the problem is there, okay? And so my standard of practice was to treat people for mold toxicity and periodically remeasure their urine tests to see if they still have the mold toxins in them. And if we're using binders at least once or twice a day, and we're 6 to 9 months into treatment and their mold toxins are not getting better, and their environment where they live is clean as best as they can determine, then I would start to treat for mold spores colonized in a person that could be producing those mold toxins, okay? And so the treatments I like using are itraconazole, like you're doing, and that itraconazole can kill mold spores in your nose passages and in your intestines. In addition, we also like to put people on a nose spray that kills mold spores as well too. And the Babesia spray is not it, okay? I'll talk about the Babesia spray that you're on here in a minute. But I sometimes would use either silver nose sprays, or colloidal silver nose sprays, I would say. Sometimes I would use nystatin nose sprays. Sometimes I would use itraconazole nose sprays. Sometimes I would use amphotericin nose sprays. But usually you also want to do a direct spray into the nasal passages as well, okay? All right. Now, in terms of the Babesia, I'll be honest, I don't know why people are doing the Babesia spray and even the microbiology diagnostic. So what they've done is they've done a nose swab on you, and they've determined probably that you are infected with a bacteria, not a mold spore, but a bacteria called Marcons, which stands for methicillin-resistant coagulase negative staph. And people do that because Dr. Richie Shoemaker, who first found that some people can have mold toxicity, developed a theory that if somebody was using binders and they didn't get better, then they must have inflammation in their body from another cause. And he postulated that that would be due to Marcons living in the nose passages, okay? And so a lot of people trained by Dr. Shoemaker still believe that and still try to do something for it. And so what the treatment is to use that Babesia nose spray to kill that bacteria. The problem is that most of us that in working in the world of Lyme have found that it's almost damn near impossible to get rid of the Marcons. You can get rid of it for a while, but it's going to come back. And most of us also found that even removing it did not help people. All right. And so in my opinion, I think Marcons is a bacteria that just lives there. I don't think it really causes us problems. All right. And it does not produce toxins. I want to be clear about that. All right. So I just don't even do that testing anymore. I know Dr. Neil Nathan doesn't do it anymore either. At least the last time I talked to him. He's had various conversations with Dr. Shoemaker, saying he just doesn't get it. Why are they doing, still going down that pathway? But they do. Okay. All right. And then in terms of your question about Bartonella, so interestingly enough, the itraconazole that you're taking, as well as methylene blue, can be a full Bartonella treatment. All right. So methylene blue, I guess this is the second time we're talking about tonight. So let me just introduce what methylene blue is here real quick. So everyone, methylene blue is a drug that is repurposed to treating Lyme and Bartonella. Okay, I'll just start by saying that. And so what it was originally designed to help with is a problem that a small percentage of people have, which is called methemoglobinemia. And in methemoglobinemia, if people are predisposed to this condition, periodically their hemoglobin, which is the protein inside your red blood cells that carries oxygen, periodically that protein doesn't release oxygen. So people become starved for oxygen and they turn blue. All right. So methylene blue is designed to help bump that oxygen off of the hemoglobin so people start having oxygen in their tissues again. All right. So that's what it's designed for. But it's been noted to have a number of other effects. One is in the world of Lyme and in Bartonella, it is useful for treating both growing and what are known as persister forms of the germ. So Lyme and Bartonella can have two growth states. They can be rapidly growing, or a small percentage of those germs will go into a hibernation state, and we call those persisters. And when they're hibernating, they ignore the regular antibiotics we use, okay? So over the last few years, there's been a hunt going on to try to find out what can we use to get rid of those persisters, and methylene blue has been discovered to be one of those things that can do that, all right? In addition, methylene blue can help your mitochondria, your cell energy factories, to produce a little bit more of their energy currency called ATP. So it sometimes helps mitochondria function. It might break down biofilms. It can help raise a level of a chemical that helps make you think called acetylcholine. So it's got a number of functions. And in fact, is being looked at in the world of Alzheimer's because of its ability to help mitochondria work better. That can improve thinking. Okay. So anyhow, so the methylene blue is useful because you can use it to break up biofilms, and it treats Lyme and it treats Bartonella growing and persister. Okay. Itraconazole is part of a family of antibiotics called the azoles. And within that family is fluconazole, for instance. And also within that family is another drug called clotrimazole. Okay, so clotrimazole is used in vaginal yeast creams and in topical fungal infection creams, all right? It's not available in a pill form. But the reason I raised clotrimazole is about 4 or 5 years ago now, there's a researcher out of Johns Hopkins University here in the States that was doing research trying to figure out what can I use to treat persister Bartonella, right? And in his studies in the lab, he took a representative of each antibiotic family. So for tetracyclines, he used doxycycline. For the macrolides, which are azithromycin or clarithromycin, he used azithromycin, all right? And for the azoles, he chose to use clotrimazole. And looking back at his studies, clotrimazole did an excellent job getting rid of growing and persister Bartonella. Just a really great job. None of us 4 or 5 years ago started using it because it's horribly absorbed, even if you have it compounded. All right. But about 1.5 years ago, I started looking back. I was looking for other ideas to help some of my patients that I was stuck on their treatment, and decided to start trying fluconazole, which is an anti-yeast medicine from that family, and started noticing some really, really good improvements with their Bartonella. All right. And correspondingly, itraconazole being part of that family, I have found to be helpful too. So at this point, you are still treating for Bartonella with methylene blue and itraconazole. Okay. All right. Anyhow, I hope that answers or helps give you some information, some things you might even want to go back and talk with your doctor about too. Okay. All right. Good luck to you. Oh, let me just do a quick screen share here again. All right, so in this Kills Bartonella article, I do talk about persisters and biofilms up here, okay? And within this article, I also talk about, there should be some information in here about methylene blue as well too. And in this article, I also talk about the azoles as being, yeah, here. I've got this one option called fluconazole-based treatments. Wherever you see fluconazole here, you could substitute in itraconazole, for instance, okay? And one of the things, as I was starting to stop doing regular clinical practice, that I did start doing quite a bit for my Bartonella treatments that were not, people were having a hard time getting well, was to start using the combination of fluconazole along with methylene blue as my main agents to treat Bartonella. I was finding some really good results with that too. Okay. All right. Thanks for our question. Good luck to you. Hello, Kelly. Hello, Dr. Ross. I've been treating Babesia with cryptolepis, which has really helped minimize my crippling nighttime tachycardia. Great. However, I have now been experiencing almost hallucinatory waking nightmares, sometimes being jolted awake throughout the night. Is this another manifestation of Babesia hijacking the autonomic system, suggesting I maybe add artemisinin, CSA, or liver kinase? Or, as it seems to coincide with much increased internal vibrations, could it be Bartonella? I recently started adding houtenilla to my herbals, 5 drops only so far, and wonder if that could be causing it, or is it just another layer of Lyme and friends appearing as I peel it? You recently said that Burrascano said that if you treat Babesia first, Bartonella is harder to treat. How does that work in practice without causing major Herx reactions to multiple herbs? All right, let's see here. Bear with me, I'm just re-looking back through here again. All right, so I'm going to make some comments. It would be helpful if you and I had an option of talking. I'd want to get some more information from you here, okay? But we don't have that as an option in this format. So, the way that I tend to recommend taking cryptolepis to treat Babesia is to pretty high dose. Is to have people do 5 milliliters of a Babesia or of a cryptolepis tincture. That's a 1:5 tincture. That means 1 part plants extracted and 5 parts alcohol, 1:5 tincture. And my recommendation is that they do a teaspoon or 5 milliliters of that 3 times a day. Now, that is a pretty hefty dose, I have to admit it. And occasionally, I have found it to be a psychiatric irritant. All right. So if you are taking that as 5 milliliters 3 times a day, and you're starting to get some of this hallucinatory waking nightmares, I just want to say it might be a side effect of the crypto. In which case, what I have my patients do is just decrease that dose. And I might even have them drop it to 5 milliliters twice a day and see what happens. All right. Now, let's say you do that, you drop your dose of your cryptolepis down, and you're about a week or 2 out, and you're still having some of these symptoms that make you wonder about Bartonella, like the nightmares and the internal vibrations. At that point, you might want to start adding more coverage to help with Bartonella too. All right, so Bartonella, the cryptolepis that you're taking for Babesia, is also useful for growing in persister Borrelia and growing in persister Bartonella. All right, another herb that you could add to help with the Bartonella would be to go with a Japanese knotweed. And I'll have people start that at a 1/4 teaspoon 3 times a day, and sometimes go up to 1/2 teaspoon 3 times a day if I want to be aggressive. Or I have had good benefit in working people up to 30 drops twice a day. Okay. But you could do that along with the cryptolepis at the same time too. And that also helps with growing and persisters as well too. Okay. All right. And then let's see here. Let's see, I'm looking at the last part of your question. You recently said that Burrascano said that if you treat Babesia first, Bartonella is hard to treat. How does that work? What my comment was, he found that even though he would get Babesia cleared, that when he started treating for Bartonella, there were some people that he found that there were more people he had difficulty getting over it compared to those that he would have treated Bartonella first. So that's what his observation was. Okay. All right. Good luck to you, Kelly. Hello, Patsy. Hi, Dr. Ross. My husband was treated for Borrelia, Bartonella, Babesia. His recent CAT scan report is as follows. Within the small bowel mesentery, soft tissues around the bowel at midline, there is a 3.5 by 3.2 centimeter well circumscribed rounded mass with dense peripheral calcification. There is patchy high density attenuation within the lesion. A peripheral calcified mesenteric mass corresponds to the finding on X-ray. This very likely represents a pseudoaneurysm of the mesenteric artery. Can these infections cause this? Oh. You know, I don't know. I haven't seen any research suggesting it, okay? And I'm postulating that if any one of them might lead to an aneurysm, it would be probably the Bartonella. Now, I hope you hear what I just said. I said, I am not aware of Bartonella ever doing this or any research showing it. But if one of the 3Bs was able to do it, it would probably be Bartonella. And the reason is Bartonella infects the endothelial lining of your red blood vessels. So the cells that line your red blood vessels, Bartonella infects that. Bartonella also releases enzymes that break down connective tissue that hold your blood vessels together. So I could see in theory that it might release enzymes that break down the tissue that keeps that blood vessel from ballooning or being an aneurysm. And that because it infects the inside lining of the blood vessels, you could see it releasing things that enzymes that break down the connective tissue. All right. So in theory, I see it might do it, but I don't know if it does for sure. Okay. All right. Good luck with that too. Yeah. Hello, Tyler. Let's see. What is your opinion on the significance of immunoglobulin level abnormalities, IgA, IgM, IgG, IgE, IgG subclasses in Lyme disease, diagnosis or treatment? And in one of his books, Dr. Horowitz states that IgG subclass IgA and IgM deficiencies are common in Lyme patients, and even says that immunologists he's consulted say low IgM levels are generally only seen with unresolved Lyme disease. You know, I'm aware of Dr. Horowitz's opinion on that. I haven't, in my practice, I did not routinely test for antibody levels. And I know Dr. Horowitz's practice, I think, I suspect he actually does that as part of his regular intake. The trouble is, even if you find all these deficiencies, there really isn't much you can do with it other than to treat for the underlying infection so you get the immune system working better, okay? Now, there are some IgG deficiencies that if you're low enough in the IgGs, you might qualify for something called intravenous immunoglobulins or IVIG, but it's awfully hard to even get insurance to pay for those. And so routinely in my practice, I just didn't go looking for them, okay? All right. Thanks for that question, Tyler. Hello, Colleen. Let's see. 2 years ago, we had a mold inspection done in my home, and a year prior, testing was done on me. Both came back positive for mold. The mold inspector recently came back and will finally be doing remediation in my home within a month. Yay, good. Should I retest since so much time has passed, or would there be no point at that? And after remediation has been done, is there a way to get the mold out of my body without also depleting my nutrients or affecting my body negatively in some way? I seem to be somewhat sensitive. Thanks for your help, Dr. Ross. So What you haven't told me here is whether you're actually using binders at this point or not to pull those mold toxins out. So everyone, if you're not familiar with mold toxins, I know we had a number of questions about it tonight already, but let me just do a quick mold toxicity 101. Okay. So based on work of Dr. Shoemaker, probably about 15, 20 years ago now, he discovered that there is a genetic profile where about 25% of people have a genetic predisposition to not be able to remove mold toxins when they get trapped in them. All right. So what happens in 75% of people, the people that don't have this problem, is they'll breathe in mold toxins from the world around them, from their home or a wet workplace. And those mold toxins get absorbed through the lungs into the bloodstream. And then some of their immune cells will see those mold toxins and tag them. And then other immune cells will come in and break down those mold toxins. And they never bother us. Okay. Now, in the 25% of people where their mold toxins don't get identified by the immune system, they don't get broken down, those mold toxins then go to the liver. And the liver is supposed to be the organ that removes fat-based toxins, and mold is a fat-based toxin, okay? And but the liver doesn't handle these well either. And in fact, it doesn't change them in a way that they can be detoxified. So they go to the liver as a fat-soluble toxin, and they come out of the liver as a fat-soluble toxin, and they get reabsorbed again right back into your bloodstream, so you can't get them out, all right? Now, if the liver was able to deal with them correctly, the liver would put a water-soluble chemical group on those toxins, and with a water-soluble chemical group on those toxins, they would mix in our poop, and we would poop them out. But again, the liver's not able to do that, okay? So what we want to do, the way we treat mold toxicity, if you have a pool of toxins that got trapped in you, the first approach is to try to pull that pool out while at the same time you're not putting any more back in. And that's where the issue is with you. You've been putting them back in because you've been living in a mold environment, even if you've been using binders, okay? My thoughts would be at this point, if I had a patient with this same situation, I would suggest after you get the home remediated to use your binders for about 6 more months and then come back and redo your urine mycotoxin test. If on the repeat test, your mycotoxins are not getting any better, and if also you are not feeling any better, then in that kind of situation, I might consider treating for mold colonization, like I discussed earlier, meaning that you have mold spores that have moved in, set up shop, and they're producing their toxins too. Okay. All right. Good luck to you. All right, everyone, I'm just going to do a quick screen here because I know we've had a number of questions about this tonight. I'll show you what you can look at here. All right. So in Treat Line by Marty Ross MD, take a look at my detoxification section here. And then look at this article called Mold Toxin Illness and Lyme Disease. I walk through how do you approach this, how do you test for it, but also I even raise in there what to do about mold colonization as well too, okay? All right. Good luck to you, Colleen. Hello, Kate. Hold on here just a minute. All right, let's see. Hi, Dr. Ross. I have been Lyme-free since 2020. Congratulations. I have prior medical history of type 1 diabetes and Hashimoto's. I have gotten the flu shot and COVID vaccines just as prescribed as my doctor. I don't normally react to flu shots, but this year I have felt pretty awful after receiving and last week, and I'm starting to wonder if it's actually just a coincidental illness at the same time. After the flu shot, my lymph node just under that arm was incredibly swollen, and I started getting really tired, and my throat hurts. It's now been 8 days, and I still feel like this. Is there an end in sight, What are your thoughts on this, whether it's from a flu shot over a week ago or otherwise? Oh, and I had my period last week too, but unsure that means much. Thank you so much. So I just want to see something here. The way you wrote this question has me thinking you got the flu shot alone. You did not get the flu shot and the COVID vaccine at the same time. Okay. So either of those vaccines, though, the flu or the COVID, it's a different, the flu vaccine this year is a different, is a vaccine against different strains of flu than last year. Okay. And different than the year before. And every year when they develop the flu vaccine for the season, they're trying to figure out what is going to be the predominant strain of flu for that year. And they develop a vaccine to target that. It could be that the strain they developed this year, your immune system is having a stronger reaction. So one possibility what happened here, even the swollen lymph node and the other symptoms you have, is still that your immune system is still reacting. And I would suspect if that's so, within about a week or so, which would mean about 2 weeks later, you should be back to a good place, okay? If not, then it's possible you've got, that you're correct. It's some kind of another infection. But if you are still having swollen nodes in about another week, I would make a trip to your physician and see if they can examine you. Swollen lymph nodes often can be, because your immune system is dealing to a vaccine, can sometimes be signs of an infection, but rarely can be signs of cancer too. Okay. I'm not trying to do a cancer scare here for you. Okay. What I'm trying to say is if things don't behave correctly, then you need to get examined to make sure we're not talking about something else going on here. Okay. All right. Good luck to you. Hello, Doug. Yeah, Dr. Ross. I have Lyme, Bartonella, and mold toxicity. I'm much further through treatment for mold toxicity with GI detox than I am with the antibiotics for Lyme and Bart. I also have the HLA gene, which means my body may have difficulty removing mold and Lyme toxins without a binder. Say I get my mold toxins down to very low levels on real time, and I'm ready to declare myself cured of the toxins. Must I stay on the binder to keep ridding myself of Lyme toxins? I've heard you say in the past that it's okay to stop the binder and only recommence if I feel worse after stopping it, which may indicate that Lyme toxins are a problem or are no longer being removed. However, my symptoms are a roller coaster, which may continue for a long time. It's likely I won't know if I'm getting worse or not until after I finish mold toxin treatment. Is there a way to stay on GI detox for an additional time without taking it every day? Thank you very much. Yeah, I mean, there are times in my practice that I would have people remain on GI detox on an ongoing basis. And those would be two reasons. Number one, if I had somebody who was using it to treat mold toxicity, not Lyme toxicity, but mold toxicity, and they could not assure that their house was clean, or we knew on a regular basis they were going out and getting re-exposed, I would have them just stay on 1 pill a day of GI detox as a means of policing the environment and mopping it up, if you will. Okay. So I'd have one pill a day. I find no problem with that. You are correct also in suggesting you don't have to do it every day. I mean, there's no science that says when you're just trying to keep up with what's being either produced by your by Borrelia or by your environment, there's no science that tells us how often do you wind up needing to take it. So you could even try every other day if you wanted to. Just experiment and see what happens with how you feel. Okay. All right. Good luck to you. All right. Hello, Danielle. Let's see. Hi, Dr. Ross. My consultant suspects Babesia as my final problem after years of treatment. Tried Malarone, but couldn't cope with psychological side effects, and now due to start clindamycin with quinine. I'm worried the quinine dose may be too high and should only be taken twice a day based on what I have read on your website. Also, any tips on how to boost the CD3, CD4, CD8 T cells? All right. So, yeah, that quinine, I would do it twice a day. I wouldn't be doing it 3 times a day if you were in my practice. Okay. That would just be my comment. I can't say they're wrong in doing it that way, but if you're worried about side effects, I would knock it down. But talk to your doctor about that. Okay. I'm not your doctor. So yeah. Okay. And then, let's see here. There's not a direct way to get your CD3, CD4, CD8 T cells up. One way, though, is to get your infections under control. Okay. Another way would be to, you could wind up taking one of the peptides. Our bodies manufacture a number of what are called peptides. Peptides are basically amino acids that are put together, and they're 40 or less amino acids. If our body puts together more than 40 amino acids, we call that a protein. But any strands of amino acids that are 40 or less, we call that a peptide. All right. Our bodies manufacture 100 or more that we know about, and each of these peptides has a certain function. Okay. One of the peptides that could be useful at trying to balance the amount of T cells you have, that's called TH1. One of those could be the peptide called BPC157. And that peptide also is useful at helping your mitochondria work better. And that peptide is also useful at doing tissue damage repair. All right. So if I'm wanting to do something for that, besides just doing germ control, I might put my patient on BPC157. It's a product here in the States that's made by a company called Integrative Therapeutics. It's 500 micrograms twice a day. All right. The other thing that you could do also that helps balance that TH1, TH2 is to use a second peptide called TB4 frag. And that also is manufactured by Integrative Peptides. They have a product called TB4 Max, and I usually have people do 1 pill twice a day on that too. But if you're wanting to start low and slow, I would go with the BPC157 first. I call that the Swiss Army knife of peptides because it does so many things. Okay. All right. And if you want more information about peptides, let me just give you a quick screen share here that you could take a look at that. All right, so I'm just going to type in the word peptides here. All right, so this is my peptides article. And in here, I review the BPC157. I also talk about the TB4 frag. That would be a useful one to consider doing as well, too. Okay. All right. All right. Thanks for the question, Daniel. Hello, Geraldine. Let's see. I'm 71, having mast cell activation flare. Have been treated for Lyme, which seems to be in remission or low activity. Being treated for mast cell activation syndrome. Have COVID vaccine available for me. Should I delay taking it until the mast cell is more under control? Ooh, that's a good question. So, Geraldine, I don't know enough of the other parts of your health status, okay, but meaning I don't know whether you have diabetes. I don't know whether you have other chronic conditions that might make it more difficult if you were to get COVID, okay? All right. What I can tell you, though, is that I would be concerned that if you have active mast cell activation at this point, that getting the vaccine may even trigger a stronger response there. Okay. So you have to weigh that out against the other healthcare risk you might face if you get COVID. And so people that, tend to have the worst outcomes with COVID are people that are immunosuppressed, probably because they're on agents that cause them to be immunosuppressed. Diabetes, kidney disease, those would be high risk factors. So if you happen to have one of those problems, even if your mast cell gets a bit worse, that might be worth doing it in those kind of situations. Okay. But if you don't have any of those problems, you might think twice about getting another COVID until you get your mast cell under control. By all means, though, talk to your physician about it to see what they have to say as well, too. Okay. All right. Good luck to you. Hello, B. Let's see. What is your opinion on the Zhang IV protocol of daptomycin, ceftriaxone, and doxycycline? My daughter has been treating the 3Bs 1.5 years with oral antibiotics, herbal supplements, methylene blue, and we feel like she should be farther along than she is. Her LMD wants to give this a try. Also, do you think IV antibiotics are a lot easier on the gut? Thank you so much. All right. So I don't think that IV antibiotics actually are that much easier on the gut, because even though you're getting them in an intravenous form from the blood vessel system, they eventually get into the gut and still cause problems. Okay. So in the end, you probably have as much difficulty with your gut microbiome, for instance, the good bacteria and germs that live in your intestines, as you would with oral antibiotics. You might get a little less side effect issues with the GI side effects, meaning like nausea, diarrhea, those kinds of things if you're not doing the oral form. But in terms of the effects on the gut microbiota, probably not much different there. Okay. All right. And then in terms of this daptomycin ceftriaxone protocol, it was specifically Dr. Zhang did not, I don't think he actually, no, he did mice experiments on it too. So he did laboratory experiments looking at this, and I believe he did mice experiments looking at it too. And he found the regimen to be useful at treating for persister Lyme. Okay. His research did not look at its ability to help with Bartonella, though, for instance. All right. So if your daughter still has Bartonella active, I can't say whether it's going to work. There are a number of my colleagues that did. I never used this protocol on my patients. First of all, daptomycin is mainly reserved for people with certain kinds of, I believe, staph or strep infections. It's ultra expensive, and usually insurance isn't going to pay for it, frankly. Not for Lyme, they won't. The reason they usually won't pay for it for Lyme, or at least I don't think they will, is because there's no science in humans saying that it's going to do anything. Okay. All right. So I was never able to put this protocol together. I do believe some of my colleagues were trying it, and I don't think that that it proved to be the big breakthrough regimen, even though laboratory experiments and mice experiments look promising for it. Okay. But it's another thing to try. I don't know that it's going to make a difference for you. And it hasn't been looked at in terms of Bartonella, and what's in that regimen will not do anything for Babesia. Okay. All right. Good luck. Hello, Caroline. How to detox from high gliotoxin load in the setting of chronic Lyme disease? Recommendations? Yeah. So your gliotoxin may have two potential sources. One is it could be coming from a wet building. In other words, you may have mold in your home or even your work environment, and you may be breathing it in and it's getting trapped in you that way. Okay. The other possibility, though, is that intestinal yeast overgrowth can lead to high gliotoxin levels as well, too. And so the first place I usually would go when I had patients that were having high gliotoxin levels was to try to clinically decide are they having too many yeast in the intestines as their source of this? All right. So symptoms that make you wonder about intestinal yeast overgrowth are increased intestinal gasiness and bloating, having quite a bit of a decline after you have things that have simple sugars in them, like cookie, candy, cake, ice cream. You just feel a lot worse afterwards. In a female, having frequent vaginal itching, vaginal discharge episodes, or vaginal yeast episodes is what I mean. Also, a symptom that can sometimes indicate that a person is having intestinal yeast overgrowth is if they're having worsened skin problems like pimples or acne or eczema type rashes or even psoriasis. And what happens in those situations is intestinal yeast release toxins that get absorbed into the bloodstream and will interact with the skin in people that are genetically susceptible and lead to pimples and acne or worsening psoriasis or eczema. Okay. So if you have a number of those things, if you answer yes to a number of those questions, as part of getting your gliotoxin out, I would want to treat for intestinal yeast overgrowth. Okay. All right. And then in terms of the binder that works best for gliotoxin, we're going to do a screen share here because I am blanking. I'm thinking bentonite clay. I think it's bentonite clay, but hold on here a minute. We're going to look at it together here. All right, so let's look at the mold toxicity article. And in there, I have, I lay out which binders work best for what. Okay, so this is my mold and Lyme toxin article. In here, I talk about binders, and I talk about what I call general binders and then specific binders. All right, so gliotoxin, yeah. Gliotoxins are bound best by bentonite clay, all right? And if you're looking for a product to use for bentonite clay, part of the problem with bentonite clay is there can be a number of products out there that have contaminants in them. The product that I like for it, so this is my supplement store. This is Marty Ross MD supplements. As you all know, anyone can purchase from here. Through this website, I try to show you what I think are the highest quality products that have the best chance of working with you. I curate based upon well-known brands that sell primarily to physicians, and they have a proven track record of putting really good active ingredients and not having a bunch of contaminants, basically. Okay. Any of you can purchase here. The advantages to you is that I sell all these products at the lowest amount allowed by the manufacturers. I don't charge you state and sales taxes. I cover that for you. And if you buy $50 or more, I pay for your shipping too. All right. So although I can't lower the prices of these products any more than what I sell them for, I do try to cut your costs by covering your taxes and covering the shipping for you. All right. So let me show you. So the product that has bentonite clay in it is called MediClay. Oops. I guess that didn't do it. Let's look over here then. There it is. I should have had a hyphen in it. So it's called MediClay FX. Okay. And this is a very clean version of bentonite clay. You could do 1 or 2 pills once a day on this one. Okay. All right. Good luck to you. Hello, Sandy. Let's see. Thanks for your webinars. Is there an herbal or something other than prescription meds for Toxoplasma gondii? That's a tough one. Not that I'm aware of, and I just have to warn you about that one. So Toxoplasma is a common infection that you can get from cats that is even found in healthy people. And in fact, most of us, if we get Toxoplasma, it basically gets walled off by the immune system. The way that doctors diagnose it is they're going to do a blood test and see if you have antibodies. And if you have antibodies, some of my colleagues are starting to treat for Toxoplasma, but having antibodies doesn't mean your immune system doesn't have it under control. And so it tends to be an infection that, unless there's a strong evidence with a brain CAT scan or severe neurologic dysfunction, I tend not to treat for that infection. And I'm not aware of what herbal antibiotics would work for that one. Okay. All right. Good luck to you. Hello, Graciela. Hold on here just a minute. Let's see. Dear Dr. Ross, I recently tested positive for Lyme, ELISA, and Immunoglobulin, which indicated IgM positive at 41 and 23. It looks like after almost 4 years of misdiagnosis and feeling sick, I finally know what to get treated for. I live in Mexico and struggle with finding some of the herbal products you recommend, as well as a qualified doctor with experience treating Lyme. However, thanks to your work, I've put together a treatment protocol I'd like to go through as soon as possible. I'd like your opinion on the following. I'm planning on starting NAC plus a herbal mix of ashwagandha, curcumin, spirulina, chlorella, camo, plus L-theanine, plus paleo diet for 4 weeks. Then a tincture that has myrrh, thyme, golden seal, powder coal, grapefruit seed extract, plus ADP oregano, plus L-theanine. Then 28 days of doxy, plus cytoquel, plus probiotics, plus aspelardi and L-theanine. Would you say this is reasonably strong, effective treatment? Is there anything I should change or add? So, in terms of the NAC and then the herbal mix of ashwagandha, curcumin, etc., those are all very useful supports to get your cytokines down, support your adrenal glands and your immune system. So I like that. And those are even things I would consider staying on. They're not necessarily going to kill your germs unless they can help your immune system work better. But they're reasonable things to look at using. Okay. All right. And I would remain on those. Okay. Then this tincture that you have of the myrrh, thyme, and golden seal, powder coal, grapefruit seed extract, and the oregano, within that, the two things that would target Lyme could be the oregano and could be the grapefruit seed extract. Now, are they strong ways of going at it? Not necessarily, but could they work for it? Yeah. But I would keep that going with your first set of tinctures as well, too. Okay. And then if you were the period where you're doing the 28 days of doxy and cytoquel, the problem with that period is the doxy is only useful at treating spirochete and intracellular Lyme. So Lyme has 3 appearances, okay? It can exist as a corkscrew. We call that the spirochete. It can actually move inside of cells and live there without its covering on it. We call that the L form. And then there's a microscopic cyst form that we call a cyst, okay? All right. In addition, all of these 3 forms can either be growing or they can be hibernating, or we call those persisters, all right? So ideally, you want to take things that are going to treat all 3 forms, and in addition, be able to address the hibernating phase of these 3 forms as well, too. All right. So your doxycycline, when you're using that, is only going to be treating intracellular growing as well as the spirochete growing. It's not doing anything for persisters. By comparison, your grapefruit seed extract will treat your cyst, and the oregano that you're on before will treat persisters and probably picks up all these other 3 growing forms as well, too. During that phase that you do the doxy, what you might do to make it a stronger treatment would be, in addition to the doxy, would be to stay on oregano, because that's going to pick up your persisters, and use grapefruit seed extract also to pick up the cyst form of the germ. And so that last period of time, if you want to be a bit stronger, I would cover for persisters and all three forms. And you can do that with doxy, grapefruit seed extract, and your oregano. Okay? All right. Good luck to you. Hello, Douglas. Let's see here. Okra 3.89, trichocethene 0.108, zearalenone 0.786. What are your thoughts? Treat mold, yes or no? This is real-time toxin test. Also, do we treat metals first if we have mold and metals? Thank you, sir. All right. So, Douglas, I don't know the normal ranges of these off the top of my head. So, unfortunately, I can't say. I would have to look at the normal ranges, and I just don't know these ones off the top of my head, so I don't know. All right. In terms of mold and metals, I generally don't do much for a metal toxicity. I used to treat it when I would find it in people, but generally I just didn't find much benefit. And so over time, I have tended not to put resources into that. I've chosen to focus more on other aspects of treatment, including getting the mold toxins out first. Okay. All right. Good luck to you. Hello, Colin. Let's see. Finally feeling hopeful after reading your book and checking out your supplement store. My question is, do you have any suggestions for people who are sensitive to alcohol? Are there alternatives to the tincture with alcohol at your store? Boy, that's a tough one. So I tend to emphasize the tinctures, the alcohol-based tinctures, because it's the strongest way of getting the active chemicals in the herbs into a source. Okay. Your other alternatives, but I don't carry them at my store, would be to use capsules that have these herbs in them. And also, there are some companies that make tinctures that instead of doing an alcohol-based extraction, they'll use glycerin as the liquid that they'll extract the active chemicals into. So that's another option for you too. There is another thing you could consider doing, though, and it all depends on how alcohol reactive you are. One thing you can do with alcohol-based tinctures is to try to steam off as much alcohol as possible to make them more palatable. And so what that could look like is you boil up some water, you put like an ounce or 2 ounces in a cup, and then you take your alcohol tincture and you put the drops of it, you literally drop them into the boiled water, and the alcohol will mostly steam off. Not 100%, but most of it will go away. And often that makes it so it's tolerable for people to do too. And then what you do is just drink that after it cools down. So that's another option for you to consider. Okay. All right. Good luck to you. Hello, Susan. Let's see. Can you discuss autoimmune encephalitis and a Cunningham panel if you've ever used? My daughter has super high result. Unfortunately, I haven't used it before to know whether it's valid or not. I'm aware of it, but I just haven't used it before. And I'm not going to be a source for you on this one, I'm afraid. All right. I'm sorry about that. Thanks for the question. Good luck to your daughter. Hello, Maria. Let's see. Hi, Dr. Ross. Do you suggest a cream or anything to use when you have a rash from mold toxicity or candida? My daughter has the rash in both her lower legs and have been putting coconut on it. Thanks so much for all your help. It's hard for me to tell. I would need to actually look at the rash to figure out what you're looking at. Okay. Now, coconut in and of itself is going to do two things. It's going to moisturize the skin, and it can have some antibacterial properties. I wouldn't think if these rashes actually are fungal, though, that it's going to do much in the way of killing it. Okay. The other thing that I would say is, as I mentioned earlier, if you happen to have intestinal yeast overgrowth, all rash problems get worse. And so, as I did earlier, take a look at my, consider if your daughter might have too many yeast in her intestines. And if you do, you want to treat that because it's going to make her skin yeast or these, whatever these skin rashes are, it's going to make them a lot better. Okay. So in terms of how do you figure out if there's too many yeast, I walked through the questions earlier, but I'm going to show you the article here real quick. All right, so take a look in my yeast section here and take a look at this article that says a silent problem is a yeast. And I walk you through how to figure out if that's what's going on, okay? All right, good luck to you. Hello, Brian. Let's see. Could you please comment on the effect of long-term antibiotics, specifically taking doxycycline, dapsone, ceftriaxone for multiple 3 to 5 years? So, you know, the biggest concern of taking any long-term antibiotics is what injury you could be doing to your gut microbiome. And so the gut microbiome, which is your bacteria, parasites, viruses, yeast, healthy yeast that live in the intestines, those bacteria, all those organisms have a job. And the research about what their job is and what they do is becoming clearer over time. In fact, we've had an exponential growth in that research over the last 5 years. It's going up quite a bit. But basically, some things that the microbiome does. Number one, it removes toxins. Number two, it aids in digestion of food. Number three, it removes things we might be allergic to. Number four, it releases chemicals that help your brain work. Number five, it releases chemicals that help your immune system work, etc. I mean, there's a whole host of things that it does. Now, in the best of all worlds, we won't put you on anything that injures it. However, we have to also consider if you've got tick-borne infections and they're really making it difficult for you to live a full functional life, at times we have to weigh out the risk and benefits of potential harm to the microbiome versus the harm of not treating your infections. Okay, so again, one issue would be just the long-term effects on your microbiome. Number two, dapsone, depending on the dosing you've been doing it and depending on what your doctor has been doing in terms of lab studies, you have to worry about dapsone causing significant bone marrow suppression, leading to severe anemia, all right? So I hope they have been keeping tabs on that for you. The other thing I want to let you know is dapsone's a hard drug. And in fact, it produces symptoms that can look a lot like active Lyme disease. I mean, people with dapsone can get cognitive dysfunction, can have body pains, can have fatigue just from being on the dapsone. So if you've been on it for a while and don't seem to be making progress, I mean, in my practice, I would consider stopping it. And I'm not telling you to stop because you should do that only after talking with your doctor, but you might consider stopping it just to see some of your remaining symptoms due to dapsone, all right? And then finally, if you've been on these this long and you're not getting better, it may be time to change to a different regimen. I mean, just because Dr. Horowitz has said dapsone is great, doesn't mean it is. And in fact, if you break apart his research, it's not that great, actually. I'll just let you know that. But clearly he believes in it, but it's not that great. In my practice, I have not seen the miracle results that Dr. Horowitz reports, okay? But even if his miracle results were true, if it's not working in you, then it's time to reconsider if you should be using different agents to treat your infections, all right? And then finally, if you've done antibiotics this long, you're not getting better, always go back and reconsider, do you have mold toxicity? Mold toxicity can create a syndrome that looks just like having active tick-borne infections. And that's because tick-borne infections And mold toxicity triggers your immune system to overproduce those cytokines that I was talking about earlier tonight. Okay, so keep that in mind as well too. Okay, all right. Good luck to you, Brian. Hello, Joe. Hello, Dr. Ross. Thank you for your helpful seminars. You're welcome. Let's see. I've been treated for rheumatoid arthritis for 35 years, and for 6 months have been treated for Lyme, BART, EBV by an LMD. My questions are, let's see, 6 months. Okay. How many months should I take doxy and xifaxamine with 1 week per month of Tindamax before knowing whether it's working for Lyme and BART? Also taking valcyclovir for EBV. Is xifaxamine a reliable substitute for rifampin? Before I decrease my methotrexate for rheumatoid arthritis, should I have some evidence of my treatment is working? Should I have a test for rheumatoid arthritis gene? How do I get one just to be sure before decreasing? Does a non-alcohol tincture of cryptolepis work just as well as an alcohol tincture? Thank you so much for all you do. All right. So xifaxamine is, I believe it's in the same family. It is a rifamycin, I believe, but it is only, it stays in the intestines. It doesn't get absorbed. And so what it was developed for is to treat for small intestine bacterial overgrowth. And one of the advantages of using it is it just works on the germs in the intestines. So no, I don't consider it an adequate substitute for rifampin. So if I look at your treatment, your doxy and Tindamax is probably a pretty effective Borrelia Lyme treatment. The doxy, though, however, is your primary treatment for Bartonella, and by itself, it would not work that well. And if your doctor, in my opinion, is using xifaxamine as a substitute for rifampin or rifabutin, I don't see it. I don't see how that works because it's not absorbed. Now, your doctor may have a different opinion on that, but that isn't what I would do. Okay. So you may want to relook at that with your physician and see if there's a way of making that a little bit stronger. Okay. In terms of the, deciding when to start cutting down on the methotrexate, that's a hard decision. I mean, some of it is you've got to look at what your symptoms are telling you. Are you starting to see improvement overall? Okay. And then I probably would go back and retest your rheumatoid arthritis test and see if they are starting to become less reactive before I start decreasing the methotrexate. At least that's how I would handle it in my practice. All right. And I would always do this with a close conversation with your prescriber of the methotrexate as well too. All right. My preference on the cryptolepis is to use the alcohol tincture. I think it's a stronger way to do it, but if you cannot tolerate the alcohol tincture, then the pill form is an option for you as well too. Okay. All right. Good luck to you, Joe. Hello, Joelle. Let's see. Hello, Dr. Ross. I've been treating for Lyme and BART for over a year, taking crypto, Japanese knotweed, and oregano, clove, cinnamon. For pain, curcumin, L-glutathione, and BCP 157. Still have disabling pain, especially in the feet. For extreme fatigue, ATP 360 and iron bisglycinate. For yeast, diflucan capri plus. Recent thyroid test, TSH 1.9, free T4 1.34, free T3 2.8, reverse T3 19.3, seems to fit Lyme pattern even though in reference range. Do you recommend thyroid meds? Thank you for your thoughts about this. So let me just make a comment. The reverse T3, I think, is a little bit high, but you'd have to see for your lab. Each lab reports these different, but every time labs report your level of thyroid, they tell you what the normal reference range is. And I think you're getting a little high in that reverse T3. It may be above the top of the reference range, okay? So let me talk about why I'm raising that as a point. So I like to think of thyroid disease and Lyme as being two types. There can be something called central thyroid disease and something called peripheral thyroid disease, okay? So your central, what I mean by that is there's a part of your brain called the hypothalamus and pituitary that is supposed to interpret what is going on with your thyroid levels and decide whether you need more. And if you do need more, then the brain releases this chemical through the hypothalamus pituitary, releases this chemical called thyroid stimulating hormone that tells your thyroid to make more thyroid hormone, okay? So what that means is a sign of low thyroid means that you should have a high TSH, all right, in theory, all right? Because again, if the brain doesn't think you're making enough, it's going to make more TSH to tell the thyroid to start making more T3 and T4, all right? All right. So one of the things that happens in chronic Lyme disease is the brain's ability to interpret the thyroid levels correctly is impaired. And the way I kind of like to describe it is all these cytokines that are floating around basically cause the brain to be drunk on cytokines. And we know drunks can't interpret things correctly. And when the brain, the hypothalamus pituitary, is drunk on cytokines, that TSH it makes may be made erroneously. All right. So we can't trust it. All right. All right. So then the next thing you look at okay, what are the T4 and T3 levels? Those are the two thyroid hormones made by your thyroid gland. And you look and you see, are they still in normal range, but do I have a possibility of increasing them to get somebody more in normal range? And to try to decide if you're going to do that, I look to see, are there symptoms of low thyroid? And so if somebody has a lot of cold intolerance, meaning that even in air conditioning and world where you have to air condition, if they're the person that's always having to put on more layers than everyone else to stay comfortable, that means cold intolerance, okay? So signs of low thyroid can be cold intolerance, weight gain, dry skin. Those would be things that make me wonder about low thyroid. And if there's enough of those going on, even if the T4 and the T3 are normal, and even if TSH is normal, I might consider giving armor thyroid or desiccated thyroid. That's a combination of T4 and T3. Okay. All right. So that's central hypothyroidism. All right. Peripheral hypothyroidism is what happens out in your cells. So your thyroid gland makes predominantly T4, about 90% roughly T4 and 10% T3. All right. And so the difference between T4 and T3, there's two. Number one, they have different numbers of iodine particles on them. All right. So T4 has 4 pieces of iodine and T3 has 3 pieces of iodine. All right. But there's another difference in that what is active in your cells, the thing that makes your cells run correctly and have a good idle speed and function well, is all T3. So that T4 has to be converted at the level of the cells into T3. All right. And so in some people that gets blocked. And the way you know if that's happened, if that's a problem, is the reverse T3. So your T4, after it leaves the thyroid gland, can be converted into T3, or it can detour and get converted into the reverse T3. And if you're having elevated levels of reverse T3, it means that you have a shortage of T3 actually in your cells. Even if you have normal levels in your blood, in your cells, you may have low T3 if you have a high reverse T3. So I'd be interested in knowing what the lab says that reverse T3 is, their normal range. And if it is above the top end of normal, the way to approach that is to not take desiccated thyroid, which is a mix of T4 and T3, but the approach is actually to take just T3. And you can do that as a prescription medicine called Cytomel. Some doctors will even get it compounded as well too. Okay. All right. If you need more information about this, I have a pretty extensive article on thyroid, and it's based on information I provided to my medical board when they did not like me a few years ago. And I was trying to explain to them why I manage thyroid the way I do. And even after I wrote that explanation to them, they still didn't like me. But I was able to put that article to good use that I wrote for them here. And so let me see. We're going to look under, where's hormones? Here we go. Under my hormone section, take a look at this article called "It's Tricky: How to Diagnose and Treat Low Thyroid." Okay. And in there, I cover the concepts of using your symptoms, differences between central and peripheral hypothyroidism, and I even review the different types of thyroid medication that I just talked about with you here too. Okay. All right. Good luck to you. Hi, Shanna. Let's see here. I was in a very minor car accident, but it seemed to activate all my Bartonella symptoms. It's been 3 weeks. Can something that minor cause such symptoms? You know, if anything that puts our bodies under stress might also suppress the immune system, which could lead to activation of something that had been under control. So it's possible, but also I would let you know from a musculoskeletal standpoint, any traumas we get in a car accident can take about a good 3 weeks to 6 weeks to settle down too. So I don't know what all your symptoms are, but if a lot of them are more muscular and joint related and even neurologic related, they may calm down still. Even though it's only been 3 weeks, it may take up to 6 weeks for those to calm down too. Okay. All right. Good luck to you. All right, everyone. That's it for me for tonight. I've enjoyed being with you here. Take a look at tomorrow morning, somewhere between 9:30 a.m. Central Standard Time, Austin, Texas time. My intention is to send an email out to you that will have an edited version of the recording for tonight, as well as a synopsis of what we talked about. Okay. In that email, you'll have an opportunity to sign up for the next webinar, which right now is scheduled for Thursday, but I think I'm going to make it Wednesday because I have another obligation I'm going to be going to on Thursday. But pay attention to that tomorrow. You'll still have an opportunity to sign up for that. Okay. And then the other thing in that email tomorrow morning, there's going to be links to my new support group. And if you like the support you're getting here, you can get more of it. You can join my Lyme United support group, where we have about 41 active members right now. I'm hoping to grow that more to about 100 active members. But in that group, we've got a group of really motivated people that are each helping each other to problem solve. But then also daily, I write responses to questions people send to me. And then once a week, I have I open up a Zoom room there where anyone that wants to talk about their whole medical problem can talk to me about that. And we problem solve together too. Our members now are starting to host their own events. And so today we had, for instance, an event there. One of our members is a psychologist and held a support group for caregivers that help take care of people that have Lyme. That turned out really well too. So it's an active, vital group. And I would invite you to look at that. Tomorrow morning's email, you'll see a link where you can do that too. And again, the group is called Lyme United. Okay. All right. So good night, everyone. And look forward to seeing you next week. Bye-bye.